Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. I'm Todd Schlosser, and today my guest is Dr. Laudito, the medical director of the Heart Institute at Palmetto General Hospital. In this conversation, we discuss why he chose to pursue a career in cardiothoracic surgery. We also really dive deep into the double mammary heart bypass surgery technique, both what it is, but also its benefits for younger bypass patients. Enjoy the conversation. So Dr. Laudito, thank you so much for joining us here today. We really appreciate you taking the time this morning to meet with us. I like to start out all the podcasts by sort of trying to figure out how these surgeons who are now sort of leaders in their field, what was it that made them want to start down the path to get into that field? So what was it that drew you to healthcare in general in your young life or whenever you developed a passion for it?
I was born in Italy, and I always had a specific interest for the men with medical problem, in pain, suffering. Very, very strangely, I was never interested in engineer. Everything was mechanical. I was always attracted to the living, breathing human being that is challenged by a significant, important health problem, and that's why it was easy the transition to be involved in a very demanding surgical field.
Yeah, so you, I believe you went to med school in Italy.
Yes.
And then you transitioned to the
I did
US.
medical school in Torino, where I did also my residency in cardiac surgery. Then I moved to New York and Manhattan and the Mount Sinai Hospital.
And you did residency at
general surgery
Okay.
there. And then I came to Miami and the University of Miami-Jackson Memorial to do my cardiothoracic training. And then I went to San Francisco to do 2 years of neonatal heart surgery.
And that was a fellowship specifically,
Exactly.
correct? Now, where you are here, that's not, you don't focus just on neonatal, correct?
Yes. We don't do neonate at Palmetto, but
Okay.
it was a step in my maturation progress as a cardiac surgeon
Sure.
that I felt to be important.
Sure. At a young age, you sort of developed that desire to help those in need. And unlike machines, you didn't want to get into that side of it. So you got into like sort of organic machinery, and there's nothing more like that, I think, than the heart. So you focused on that cardiac space. And now, I know that you wanted to talk today about a specific technique in that cardiac space. And
The double
technique.
mammary is one of the techniques of myocardial revascularization. The coronary artery bypass is the most common cardiac surgery procedure performed in the world and in the United States, of
Sure.
course. But it's very shocking that the highest quality treatment that you can deliver with this technique is offered just by 4% of the hospital in United States. Coronary artery bypass, that means jump the blockage of the coronary with the bridges created by vein that we take from the leg, or from artery that are present in the chest of the patient, or from artery that can be harvested from the forearm of the patient. And coronary artery bypass by itself is a palliative procedure, means we are not taking care of the source of the problem, and we offer a relief of symptom, improving the oxygenation of the heart, the blood supply of the heart. And there are ways to do that. Standard of care nowadays is using one mammary artery that is harvested from the left side of the breastbone. The mammary artery proximally stay attached, as you can see in this diagram, and one mammary get suture on the most important vessel of the heart, that is the left anterior descending, and all the rest of the revascularization bypasses are performed with vein. Vein are inferior conduit. They have patency rate very limited. 10 years is 50%. And considering that the patient population is getting younger, sicker, you need to provide a surgical solution that give to our patient a good mileage. So just doing Lima, the left mammary, with the vein nowadays in the young patient is not enough, and there is data like this issue of September 10, 2019 of the American College of Cardiology is showing the surgical option.
Is it because the patient population that is getting younger, and obviously everything you're doing in surgery is to improve, future quality of life, right?
Yes.
So the patient population having been older in the past, did it just not matter as much? Like the veins being inferior, as you were talking about, did it just not matter as much because they were already later in life and they couldn't do it? So,
Correct.
But now that they're coming in, do you mind if I ask some specifics around that? Okay.
Please.
So just because I don't know, and I think some of our listeners may not
course.
know, how old was the population that comes in for cardiac surgery, or specifically a bypass surgery, let's say 20 years ago?
But the young patients are always present in the patient population, but 20, 30 years ago, you were accustomed to treat a patient that was having number one, more limited disease, didn't come with all these comorbidity, are the problem that make the surgery and the recovery extremely difficult. They were around 70, 75 years old. And with the very isolated problem, they would get a very good outcome were properly treated. Nowadays, they come much younger. My youngest patient to receive coronary bypass was a friend of mine playing soccer. He was 36. Of course, there is a familiarity, but it's not a surprise to have a 45 average patient. And here at Palmetto, we are one of those institutions that for what I would consider patient below 65, the question is why they should not have the double mammary. So it's the opposite.
Yeah, well, that
those
makes sense.
people should have the highest quality, but you need to also appreciate that this highest quality is burdened by a procedure that is very technical, is very time-consuming because it's the surgeon doing the harvesting of both mammary. Instead, in other cases, like the radial, can be an assistant. So it's time-consuming, it's technically demanding, meaning you need to realize that the vein are much more tolerable artery. And this kind of artery, extremely delicate. Don't want to bother baby heart surgery, but you need to have the kind of touch to deal with this kind of artery. So the intensity and the complexity of the surgery is bigger, and also, of course, taking both mammary that they travel along the breastbone, right and left, the vascular supply of the bone is reduced and the incidence of infection is slightly increased. So there is no room for forgiveness. So as a surgeon, we are under tremendous pressure because we are offering something that is out of the mainstream. And so if something goes wrong, you get crucified inappropriately.
You're sort of scrutinized more.
Exactly.
Yeah. And you said only 4% of
The
done
hospital
like
in
this?
United States offer this kind of treatment. At Palmetto, I think, is one of the hospital in Florida with the highest number of these
Oh, wow, okay.
technique that we offer to patients.
So can I ask, from a patient perspective, if I was coming in for a bypass surgery, I'm relatively young, why would I want the double mammary as opposed to the sort of what I would call what used to be done, a regular sort of bypass? What are the benefits to the patient?
But the double mammary is, and the way I do that is a recognized way, is the most simple. When I say simple, means the less conducive of complication, technical and from outcome, because I take these two mammary, I dissected them free, I detached them lower close to the diaphragm, and so they are free, and the left goes to the left side to the heart, the circumflex, the right go to the main vessel of the heart, the left anterior descending. Now, to do this in a free tension way, a lot of time need to be spent in isolating the right mammary from the all the way to the subclavia. And that's a required time that is well appreciated when you are completing the procedure, because this vessel need to be tension free. Now, these two vessels, they are inside to mean they are connected to the main artery, are a life conduit. So as a surgeon, we have been confusing a little bit the horizon, starting to cut this artery and suture in other place. When you detach, they are not anymore a life conduit, and so they lose the ability to deliver a medication called nitric oxide that is beneficial for the heart, is a vasodilator, and has evidence that can delay the progression of coronary disease.
It sounds like it will not only lead to, well, I mean, just better outcomes in the future,
and there
right?
is data, the question that the data show good benefit at 10 and 15 years. That's why the patient need to have the lifespan to achieve the benefit of the data.
Because, you know, back 30 years ago, as you were saying, your average patient being 70, 75, 25
would
years
not
out.
have the possibility to experience the benefit of this. Now, these patient study are, in the literature you can find support for everything you want to sustain.
Absolutely.
But there is a very strong, solid data that says, especially in the young diabetic male, this kind of surgery is the way to go for a long positive outcome. And of course, is here at Palmetto, as I said, we have the highest number, I think, in the state for using selectively double mammary on patients less than 65.
Right.
And we recommend that because is the solution to their coronary disease to become surgical. Because if you operate a young guy, you do the traditional lima and vein, you know that in 10, 15 years the patient will be back. You can almost schedule the next surgery because the vein will close.
Yeah.
When you put double mammary, the patient can have other problem with coronary, but nothing that will require surgery.
Okay, so you're pretty much preventing them to have to come back in.
As a surgical patient.
Right, so again, when they were 30 years ago, when they were 75, 10, 15, 20 years, they probably have other things that led to end of life. With this, if you're operating on someone who's 45, they hopefully have 30, 40 years left in them. So you're setting them up for success long term.
Exactly.
That makes sense.
But it's important to stress that the amount of pressure that we as a surgeon are exposed, because besides being scrutinized, the risk and the benefit that in this case are significant for the patient. From surgical point of view, you are exposed to a pressure and a slight higher risk of complication that can be giving a wrong impression on this surgery.
Sure, and I'd imagine that this is a newer technique than the other bypass.
Actually, and I'm very kind of proud where my interest started. The first paper coming out of in the public literature about double mammary in the United States is coming from Miami, and one of the writer, Dr. Trad, was my personal teacher in my training cardiac surgery in Miami. That's why I always had early in my career my eyes open toward this outcome and be sensitive to the benefit. So it's been 30 years monitoring this, realizing in the last 10-12 years is a routine for patients less than 65 years old.
So do you mind if I ask, if it's been around for 30 or so years, what has slowed the adoption rate to make that sort of the standard of care? Very
good point. So let's make number one is the technical demand. So this is something that needs to be done by experienced people, number one. Number two, require more time, double time. Number three, you have a slight incidence of complication for infection of the breastbone, but dealing with artery is not as vain. Mistakes are not accepted in this technical suturing, because a vein you can redo, the artery will be beat up. So the room for forgiveness in your surgery is dramatically decreased, and you are raising significantly the intensity of your procedure, without going to mention that the second mammary is not recompensated like the first mammary. That is totally nonsense. So there are pressure from outside that are intimidating surgeon to choose this kind of technique despite the clear benefit because of these factors. It's very important also to clarify that when I talk about double mammary, in the paper I mentioned for Journal of American Cardiology, you have the visualization of the arterial reconstruction. I refer to the first one, that is the right mammary crossing and going to the LAD, and the left mammary going to the circumflex artery. Those two strategies have been confirmed to make a difference in survival at 10 and 15 years by Cleveland Clinic long-term data with thousands of patients, where this benefit is not seen if we use the right mammary over the right coronary. Number one. Number two, the way that I use the mammary is in situ, attached, so they are living conduit. I'm not considering to cut the right mammary, because it's going to be quicker for you to get the mammary available if you cut and you sew it back again, but will not be the same outcome. Even the data nowadays doesn't clearly differentiate the difference between a transected mammary and in situ mammary. I strongly believe in 20 years will be very evident that in situ mammary will offer a better outcome than the mammary that has been cut.
Yeah, it seems like the data is sort of already showing that. You just need more time to prove it long term.
Correct.
And since the patients are getting younger, you're getting that time because they're living longer.
And it's important to educate not just the patient, but the cardiology. If your patient is less than 65 years old, the question should be why. There is any reason he should not have the best treatment with the best outcome. That means double mammary. And I want to reassert again that this double mammary, the way I perform, is the most simple with the less prone to complication. There is other form of arterial reconstruction that you start to make adjunct so piece of artery to piece of artery, where you just increase the risk because every single surgical maneuver comes with the risk of failure.
Yeah, and the longer you're in the operating table,
exactly.
all that stuff. I'd like to, if I can, sort of close with two questions. Because if I was at my age, or maybe a little bit older, and I was having heart issues and needed a bypass, I would want to do this. I'd want to seek out someone who could do this technique. So as a patient, how do you find out about, or how do you know if the surgeon you're going to does this? And how do you, like, if I wanted to come down here and do it, how would I go about doing that?
It's very easy. On the website, you can find all the right and the wrong information. So that's why I always say to my patient, let me be your Google, because Googling is not always the answer. But one thing I feel very strong, that your surgeon should deliver to you the procedure that you feel more comfortable. Do not push your surgeon to do something he's not comfortable to. And second, we at Palmetto are available 25 hours a day to our patient. And especially we are very strong in this kind of surgical treatment because we believe it. We have been, as I said, since my training in Miami in the late 90s with Dr. Trad, I saw this training evolve. Unfortunately, as a surgeon, we didn't do a good job to clearly isolate and classify the outcome of this. We throw in the middle all other artery like radial that don't have the same quality and outcome like the right mammary. Or sometimes we cut the right mammary. I always say it's cutting the wings to eagles. How can you expect to fly? So again, the BIMA patient, BIMA is a BIMA, bilateral internal mammary artery. You see, since you do that in surgery, before you close the chest, if you do the right choice, their heart is different than the other. Is energized, is the blood supply of two pumping artery. When you have the experience to deliver that, shows already in surgery a dramatic difference.
Do all cardiac surgeons learn this technique while they're coming up?
Is available to everybody according to your training, your mentor. You have a different, sometimes pressure from the market. Because you need to be aware that in the private market, when time and money is the essence, sometimes in the long horizon, we forget that patient priority is number one.
Absolutely. So if I was a surgeon that maybe learned this technique but haven't done it, since residency, how do I brush up on this type of procedure? Is there?
I am available. There are nowadays video available, but it's very important to talk to people that is very passionate about this, because the way you see this, doing double mammary is not really the sewing of the vessel to the heart. The most important part is the harvesting technique and the preparation, because at the moment I'm going to sew the mammary on the heart, the preparation technique I use, my mammary go through a process, almost a marination. I put to marinate in a special container before I saw them, and they get enlarged, vasodilated, that they look bigger vessel than what they originally are, like I used to say, mini femoral. And for the patient, I always like to say that when you talk to your patient with your heart in your hands, they do not have hesitation to put their heart in your hands.
I'm sure that that's true. And that's more of a mindset, I'm sure.
Yes.
You know. Well, Dr. Laudito, thank you so much for taking the time to both be on the podcast but explain this technique.
It's been a privilege talking to you, and I want to thank you to allow me to give voice to a treatment that has been muted so far.
Well, I'm happy to do it. Thank you so much.
Thank you.